I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. We are live from the 2022 NEI Synapse, and I have here with me today Dr. David Goodman, who just finished his presentation on ADHD, hormones, and menopause. I'm so excited to give people the chance to get some of their unanswered questions addressed today. Welcome, Dr. Goodman.
Hi, thanks for having me.
My first question for you is, in the case of a woman with major depressive disorder, or MDD, with significant worsening of depression during menses, do we diagnose both MDD and premenstrual dysphoric disorder, or PMDD, or is it exacerbation of the primary diagnosis?
So in this case, I would say that the MDD is separate from the major depression. The neural pathways are probably different in the exacerbation of PMDD symptoms as a result of the heightened progesterone during that period of time and the decline in the estrogen. This would be in contrast to major depression, whose basic episode is not hormonally influenced. So for me, I would separate out the major depressive disorder and the PMDD. If the patient is already on antidepressants or medication for the MDD and the PMDD remains problematic, then consider using oral contraceptives to reduce the symptoms of the PMDD, which is again largely mediated by the hormonal fluctuations.
Next question. If ADHD is a lifetime illness, how can you say that prevalence is higher in boys, but prevalence in adults is equally distributed? Are you suggesting that ADHD in women develops at menarche, or are we not very good at diagnosing girls?
Well, this is a good question. It comes up very frequently because I will say boys get diagnosed more frequently than girls in childhood at a ratio of 2-to-1 or 3-to-1. And often the boys are diagnosed because of their hyperactive impulsive behavior. So they become problematic behavioral management issues in a classroom or at home in relationship to socializing with their peers as well. So the boys get diagnosed because they're problematic to other people. As ADHD individuals age into adolescence, then you start seeing that inattention and disorganization becomes more of a problem because academic demands increase as the children age into middle school and certainly high school. It's not that ADHD doesn't exist in the girls' childhood. It's that we don't identify it because the level of impairment doesn't become evident until they get older, and they don't present with the problematic hyperactive and impulsive behavior. So with that explanation, ADHD is probably more common, is probably equally common. It's just when they're getting diagnosed in the course of their symptoms and their age.
Next question. What about women who have had estrogen-related breast cancer and are on estrogen blocking meds and have ADHD?
Yeah, this is a really good question and has been coming up in my practice. So estrogen blocking medications for breast cancer in and of themselves will cause cognitive problems. And so you have women who are being treated for breast cancer on these medications, and they'll complain about a cognitive processing slowness. If you have ADHD, then that cognitive impairment is exacerbated by the presence of these medications. And the question for the ADHD woman on estrogen blocking medications, you might be able to overcome this with a higher dose of ADHD medication. Is there any research to support that? Absolutely not a shred. So this is just my clinical approach to this. If you have women who have estrogen blocking medications for breast cancer who don't have ADHD, Then the question is, would you consider using stimulant medication for this period of time? And the answer to that for me has been yes. But I don't think that there's very much research, again, for a clinician to rely on. So these are great questions, very important, clinically relevant questions that come up in my population and obviously in the population of patients that this questionnaire is serving.
With the critical window hypothesis, if women start hormone replacement therapy before the age of 60, but continue it into their 60 plus years, is there still a negative effect on cognitive impairment?
So the answer to that is not, because during the window of opportunity, the critical window hypothesis, there's a period of time where the brain is changing, but still receptive to HRT and its impact on cognition and emotion regulation. That then probably retards aging process. So benefit of HRT is likely carried out longer. And so you don't encounter that negative effect. Now, you can't keep somebody on HRT indefinitely. And then the question is, at what point do you say the risk is now higher than the benefit and you taper people off of the HRT?
This next question says, may you please address conditions such as polycystic ovarian syndrome or PCOS in women with ADHD and how to best manage their ADHD symptoms with respect to PCOS?
Okay, so again, these are great questions because there's complicating overlapping symptoms. If you look at women with PCOS that don't have ADHD, there is an association to cognitive symptoms of inattention in PCOS in and of itself. Then if you have somebody with PCOS and ADHD, that cognitive difficulty is compounded. So for my patients who have PCOS, and I have several, and ADHD, I just treat the ADHD as I would ordinarily. PCOS is simply there on the table. It's a medical comorbidity, but it's not necessarily impacting how I adjust medications accordingly for the ADHD.
Next question. Given that elevated testosterone was associated with increased ADHD symptoms, is there any indication or evidence that other hormonal disease processes, such as PCOS, might be associated with ADHD?
So in my talk, I spoke about the menstrual cycle, the follicular phase where estrogen is rising until it peaks at ovulation when FSH and LH increase. And then we have a decline in estrogen and an increase in progesterone. So progesterone will decrease the benefit of estrogen as it rises. PCOS is an issue of elevated testosterone. So testosterone's impact on cognition is separate than the progesterone estrogen impact on cognition. But again, when I'm treating these patients, I'm often treating the ADHD.
Right.
And the PCOS is there, but it's not a consideration. I don't modify my dosing of stimulant medication for ADHD because they have PCOS or because they don't have PCOS.
Next question. How does estrogen affect the different dopamine pathways?
So estrogen will sensitize dopamine receptors, and because of the neural networks of dopamine from the hypothalamus and the amygdala and the hippocampus up through the prefrontal cortex, you then get a beneficial effect of estrogen on emotional regulation and cognitive processing. When estrogen declines, both in the luteal phase and also the menopausal phase, you get a decline in those abilities. So it's a decline in cognitive ability with inattention and slower processing speed, as well as emotional reactivity and a decrease in emotional resilience.
What is the maximum age that you would recommend for stimulants?
So this is a complicated question. Let me start with the package inserts of most of the stimulant medications. Most of the stimulant medications have max ages of 65, except for lisdexamfetamine, which is age 55. Those ages were established by the clinical protocols that were submitted to the FDA for the specific products. The companies have not pursued older adults with ADHD in part because of the comorbid medical illnesses and the comorbid polypharmacy of multiple medications. So rather than try to study a stimulant medication in older adults, they forego that because the adverse events and all of the complications of sorting out the data interpretation is very complicated. It'd be very difficult to recruit 65, 70, 75-year-old subjects who don't have medical illnesses or are on no other medication. So going to the question though specifically, what would be my maximum age? That age is not determined by age as it is determined by medical comorbidity. So depending on the medical status and specifically cardiac status. So there are patients who are post-MI, patent ductus ovale, right bundle branch block, atrial fibrillation, ventricular SVTs, the ventricular tachycardia. Those have to be evaluated generally by a cardiologist. But if the impact of cognition is problematic enough, then I would start with a low-dose stimulant, short-acting or long-acting, depending on your preference here, because we're talking about older adults for which there's no recommended treatment guidelines, by the way. And then titrate accordingly, monitoring vital signs, especially, and other medical illnesses. So I don't have a max age. I do have a couple of patients who are over the age of 80, early 80s, who benefit from these medications, and they're not bothered by side effects or hemodynamic changes. But I've nailed down the diagnosis, and that's what's critical here. The diagnosis has been made as best as I can. It's not, I have cognitive problems, touch me with stimulants and let me see what happens. I don't make a diagnosis based on medication response, because if you give these medications to the average person, they'll say they're ruined their energy and cognition is better. It doesn't mean you have ADHD. It means I've manipulated dopamine and norepinephrine, and that's the psychological experience.
Is there a correlation between women who have had their ovaries removed and higher rates of dementia?
So this is a bit beyond my expertise. I will say that there are cognitive and emotional changes as a result of having a bilateral ovarian resection, but I don't know what the correlation is with higher rates of dementia. It wouldn't surprise me if there was an association. I just can't cite the research to give you a research-based answer.
Next question. Are there any recommendations or studies on helping women with cognitive changes or attention deficits related to hormone suppressive therapy for cancer treatment?
So we know that estrogen blocking agents for breast cancer will cause cognitive and emotional changes. That's, again, we talked earlier about estrogen being pro-cognitive. And so if you do anything that's going to diminish the effect of estrogen, you're going to have an effect on attentional ability, cognitive ability, and emotional resilience. So in that regard, I generally will treat people who have ADHD with stimulant medication. Question becomes, if you have cognitive changes with estrogen suppressing drugs, will they respond to stimulant medication? In clinical practice, I will try that to see if there's a beneficial effect. I'm not sure that there's a body of literature that would support this one way or the other.
Have you ever had a patient who took stimulants only in their luteal phase?
I have not. I've had patients who take stimulants on an as-needed basis, but they don't do it regularly in the late luteal phase. Having said that, I have some patients who say the effect of the medicine appears to be better in their late luteal phase than how they function without medication. But I generally don't have patients who just take it to the luteal phase. Now, this is in contrast with PMDD. It used to be recommended that patients could take fluoxetine just during the late phase of menses.
This takes me to our last question, which is, I have a female patient with ADHD and PMDD. She was already taking an oral contraceptive and SSRI and yet still had untreated PMDD symptoms that only gabapentin could treat. What would be your explanation for this, or have you seen similar cases?
I don't have an explanation. I don't think there's any research on gabapentin in PMDD, so it's hard for me to comment one way or the other. I have not used gabapentin in PMDD, so I don't have any clinical experience with that. What would be interesting, if it could be done in clinical practice, is whether or not you can do a placebo to make this determination. But that's something I would consider academic and not necessarily clinical. So just whenever you have patients who respond to medications in an atypical fashion, I don't dismiss their response. I just keep in mind whether or not the response is a placebo effect, and how would I distinguish that versus a pharmacologic effect that we can't quite explain.
Thank you so much, Dr. Goodman, for joining us and for sharing such excellent information with us. And thank you, all of you, for joining us on our show.
Thank you again. Enjoy.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.